you, ma'am. Dr. Shona Nag, you can start the presentation. We welcome you all.
Talk on breast tumors and molecular markers. I'll try and put in a clinician's perspective and also make sure I cover all the basic biomarkers. There will be some that are left out, but then that's beyond the scope of this lecture. So I've planned the talk in such a manner that we first introduce the breast cancer in India. We talk of a few definitions and concepts, evolution and classification of biomarkers in breast cancer, focus on clinical and molecular subtypes, put forth a few case scenarios, especially for ER positive and triple negative breast cancer, and their relative markers, and finally end with what the future holds. So if you look at the epidemiology, and this data is from GloboCan, which is a subsidiary of the WHO and the IARC, you can see that in 2020, there were almost 1.8 new lakh breast cancer cases. So this is the most common cancer, not only amongst females, all ages, but also among both sexes. It makes up about 26% of all women cancers. So in a general oncology clinic run for women, 1 out of 4 women that you see are found to have breast cancer. What about overall? It makes up 13% of all cancers. Look down below at the row that I've outlined with the red circle. If there are 1.8 new cases, there are also 90,000 deaths. So this is telling us something, and this is something we really need to act on. 30% of patients in India had early breast cancer in this study, while the same proportion in the US, and this is from the SEER database in the US, which is a population-based registry, was 80%. So you can see that very few patients come with localized only disease. By that I mean confined to breast. Many come with axillary nodes and other supraclad or intramammary nodes. And this data is from the Cancer Registry program. This alludes to either a late diagnosis at presentation due to lack of awareness or lack of accessibility to proper care. Let's go into definitions of a biomarker. And according to the National Cancer Institute, it's a biological molecule found in blood or other fluids that is a sign of a normal or abnormal process or of a condition or disease. It can also be used to see how well the body responds to treatment or for a disease or condition, and it's also referred to as a molecular marker and signature molecule. Let's put it more simply. It is a measurement variable which is associated with a disease outcome. It can be a single measurement, for example, a PSA level, or a combination of variables, and I will be talking about this a little later. A genomic classifier, for example, Oncotype DX. We need to differentiate between a prognostic and a predictive biomarker. A prognostic biomarker informs about a likely cancer outcome, be it recurrence or death, independent of the treatment given. For example, we know that a higher grade of tumor does tell us that the patient is going to do poorly. A large number of positive nodes is also going to tell us that irrespective of treatment, this patient is at a high risk of disease recurrence. A predictive biomarker is one that if the treatment effect, and here you do need 2 arms, be it an experimental and a control arm, and it is predicted if the treatment effect is different for the biomarker positive patients compared to the biomarker negative patients. For example, you have an estrogen receptor status. If the patient is ER negative, that patient is less likely to respond to hormonal therapy. Whereas if the patient is ER positive, they are more likely to respond to hormonal therapy. So let's look at it a little bit more in detail. And for those who want to go into the depths of biomarkers, this is an excellent article in JCO published in 2015. So you can see various, in the cartoon, you can see A, B, and C. In A, so the blue basically stands for the treated group, and the yellow dotted line is for the non-treated group. On your left-hand side, you have biomarker negative. On the right-hand side, you have the biomarker positive. In A, you can see, irrespective of the treatment, in both groups, the biomarker has shown, the presence of the biomarker has shown a better prognosis. So this is a purely prognostic biomarker. In B, you can see that only those having the biomarker and are treated are benefiting. So this is a purely predictive biomarker. And in C, you can see not only is the treatment effect for the treated group, as I said in the blue line, it's also a prognostic biomarker because compared to the baseline in the biomarker negative group, you can see the yellow dotted line has gone up. So this is both predictive and prognostic. It's not that simple. Markers are rarely purely prognostic or predictive. They are usually a mixture of the two. Now, what do we look for in a biomarker? These are very important concepts. You need analytical validity, clinical validity, and clinical utility. Analytical validity is it reproducible, and it deals with sensitivity and specificity, and of course, accuracy and prediction in the measurement. Clinical validity is when it correlates with the outcome and it separates out the population into two different outcome groups. Clinical utility is much more difficult to prove. It has to be useful to the patient, and it has to be that the care of the patient has improved by using the tumor biomarker test. Now, what do I do in the clinic and what do I look for in a biomarker? There are two questions in breast cancer. The first is who needs treatment, and the second question is which treatment is the best. When I say who needs treatment, the purpose is to avoid under and over treatment. So I need a good prognostic factor. So I get to know that even without treatment, this patient is going to do well. All right. When I want to know which treatment is best and I want to individualize it, I need a good predictive marker. So I need to know that if this patient has this biomarker, this is the treatment that will result in a great outcome. So this is the clinical relevance. Now, we've come a long way for breast cancer. We started with the AGCC staging, first to seventh. We looked at tumor size. We looked at lymph node metastasis, distant metastasis. We then went to the 8th edition, which for the first time included estrogen and progesterone receptor, the HER2 receptor, and Ki67. It also included genomic assays such as Oncotype DX and MammaPrint. And we have now come into the precision oncology era, which is the NGS. And there is a genomic classification which is based on whole genome sequencing, exome sequencing, and the advent of liquid biopsies, which I will touch on a bit later. Now, to put it very simply, let's look at prognostic markers because they're still very, very important for a clinician to make decisions. So tumor size, nodal status, invaluable, because even within a certain subtype of breast cancer, these two hold good and these two will also influence the ultimate outcome. Histological type, histological grade, lymphovascular invasion, and finally ER/PR HER2 status. So let's not forget histology. A tubular cancer, as you can see on the left, is seen commonly with ER/PR positive. And when I get such tumors, they are often small, node negative, and they do extremely well with hormonal therapy alone. Whereas on your right side, you see a variant of the triple negative group, the metaplastic type, which really carries a horrendous prognosis because these are very stem cell-like tumors and they're extremely chemoresistant. Although chemotherapy, as you know, for triple negative is the only treatment that exists in the early setting today. Of course, immunotherapy has just come in. And what about grade? And does it matter? Yes, it matters to me because when I see a patient with a very strong ER/PR and a grade 3 tumor, that makes me wonder, is there something in the biology that I'm missing? So a grade 3 tumor is important, a grade 1 is important so as to avoid therapies, but we know that grade 2 is the one that is misreported by most pathologists. We of course use the Bloom-Richardson grade, and this is something you're all conversant with, using tubule formation, nuclear pleomorphism, and the mitotic count. What about lymphovascular invasion? This has much more meaning when it's taken together with grade. Alone, it's not such a great prognostic factor. But in patients with poor grade and presence of LVI, it does portend a poor prognosis. And you can see the antivascular antibody CD34 with strong staining in the cartoon below here. There have been many ways that people have tried to measure proliferation, and the mitotic index is one of them. The Ki67 is another. And it's been a bit of a nightmare because there is a international Ki67 breast cancer working group established. No one really knows the cutoff. We know that less than 10% is great because it tells us that it's not a very proliferative tumor. We know that more than 30% is bad because we know these are highly proliferative tumors, but we don't know what's happening in between. Do I use it to really make decisions? Not really. It's only when I have a grade 2 tumor, strongly ER/PR positive, I like to get a sense of the Ki67, especially when my patient can't afford a genomic test. If I had to sum it up, ER and HER2 remain the most important predictive markers for breast cancer till today, both in the early and the metastatic setting. And there's been a big debate about the cutoff. The ER, as you know, is a nuclear receptor. It's trained strong brown. And when you have a ER negative tumor, it's very important to establish a breast cancer origin by doing other things like GATA3. The cutoff was earlier less than 1%. But now we know that there is something known as a HER2 low, ER low positive that is less than 10%. And as clinicians, we know these are the patients that don't do very well with hormonal therapy. They behave a little more like their triple negative counterparts. So if I get a young woman who's coming to me in the clinic and she has a really ER low tumor, I would be very excited to give her chemotherapy. E-cadherin is very important for establishing the diagnosis of lobular. Lobular diagnosis is really very important, especially in the neoadjuvant and adjuvant setting. These are usually ER positive tumors, except for the pleomorphic and the other varieties that are HER2 positive, and they don't respond very well to chemotherapy. This is the Alred score that you're all conversant with. So when I see a score and the total is on 8, and then when I see a 7/8 or an 8/8 that is strong ER positive, I'm very happy. When it is between 5 and 6, okay, there is an intermediate positivity. But when I have anything 0 to 3, I'm a little concerned because I know this patient is not going to behave like your traditional luminal type of breast cancer. What about PR? So there used to be a lot of artifacts earlier, and people used to get a lot of false PR positivity. It is very rare to get ER negative and PR positive tumors, but you do get them in 5%. And when that happens, and the PR is truly positive, remember that a PR positive does indicate that the ER pathway is active, and there are studies to show that these patients may benefit from some hormonal therapy. The HER2 is the most fascinating receptor, and we go on IHC from 0 to 3, and by FISH we have amplified with a ratio more than 2, or we have a copy number of more than 6, and there are a lot of intermediates in between. This new entity, Dr. Baljeet will also talk about. So 0 today is considered as true negative. We have the HER2 low, 1 and 2. If you have a HER2 plus, it is equivocal by IHC. You need to confirm it by FISH. 20 to 25% will be FISH positive, but majority over 75 will be HER2 FISH negative. So These are the prognostic and predictive values. There is a great technical validation in ER, PR, HER2. There is clinical validation for both ER and HER2. As you can see, key 67, there is no technical or clinical validation. So IHC is recommended for ER and PR and HER2, and more than 10% of cells with complete staining is what is defined as positive, and when you mentioned a copy number of more than 6 or ratio of HER2 to chromosome 17 more than or equal to 2. Okay, I think I'm frozen here. Oh dear. Akhil, can you help out?
I think you have to exit the marker pointer. You've started the pointer.
Oh dear.
Yes.
So how do I, 1 minute, how do I exit it?
Do you need any help?
1 minute. Yes, I can't get out of this annotation. 1 minute.
You reject it. Don't accept.
Let me just.
It's
Okay,
done.
all right. Yes, thank you.
I request the students and audiences, please do not request for annotation to the speaker. It's just irritating. So avoid pressing on that annotation button which appears on your cell phone. Thank you. Yeah.
All right, so sorry about that. So as a clinician, to understand breast cancer, based on ER, PR, and HER2, we divide it very simply into 3 biological subtypes. And these dictate the clinical outcome and the response. So if you look at the cartoon below, you can see we have 65 to 75% of ER positives. This is different in India. It's lower, it's 50 to 60%, perhaps reflecting the younger age of our population and younger age of our breast cancer patients. HER2 is about 15 to 20%, and triple negative, which is 15% in the West, is 25 to 30% in India. And in our data, I think of almost 1,000 patients, we had triple negatives making up 26.7%. So there are some words of caution while testing, and there are lots of sources of variability. And yes, pre-analytical, analytical, and post-analytical factors are very important. When you're talking of cold ischemia time, when you're talking of the time the biopsy is done to the time it's put in the preservative, it's paramount that it be less than 1 hour. Then the type of fixation you're looking for, the calibration in the lab, the procedures, the competence, the antigen retrieval. I mean, ER and PR are delicate stains, and if you wash too hard, you can just wash them off. So post-analytical is also very important. It depends on the interpreter, the reporting, and the scoring system that is used. So please pay a lot of attention to this when reporting. And this is a very interesting study that was published about 10, 12 years ago. And you can see that the incidence of ER-PR negativity depended on the day on which the pathology sample was sent to the lab. And you can see a relatively high amount of negativity on the weekends. There was nobody to process it. And probably the time to fixation was over time. So things like this matter, and they make a difference to outcome, because you would deny some of these patients hormonal therapy. So let's talk of ER positive breast cancer and some interesting molecular markers which have come up within this subtype. So I've put forward a case of a 60-year-old postmenopausal lady. She's a teacher and was operated for a breast lump. And the histopathology showed a T2 3-centimeter tumor, 1 node positive, invasive ductal. And her IHC was strong ER-PR, ER 80%, PR 70%, HER2 1 plus, grade 2, and a Ki67 of 15%. And she's hell-bent on avoiding chemotherapy. We very often see this sort of patient in the clinic. So there are tools and there are certain formulas that we have learned from our undergrad and our postgrad experience where we can actually calculate the risk of relapse when the patient walks in with these tumor characteristics. So I opted to use the Predict Online tool, which tells you at 10 years, women after surgery and their chances of overall survival. So with surgery alone at 10 years is 69%. If there was no breast cancer, this would be 91%. You add hormonal therapy, you get a 6.4% benefit, and you add chemo and you get another 3%. So you bring her up from 69 to 79%. So once she knows that she does have some benefit from chemo, it's not negligible, she's still asking for another test because she really wants to avoid the toxicity. So I'm going to digress a little bit and tell you that the Cancer Genome Atlas has opened up a whole new world for us. It has molecularly characterized over 20,000 primary cancers in matched normal samples spanning 33 cancer types, and it began way back with the Human Genome Project in 2006. And it gives us mutations, copy numbers, gene expression, DNA methylation, microRNAs, gene fusions, etc. A landmark paper in 2000 by Chuck Peru and his colleagues in Nature analyzed and characterized the gene expression patterns in 65 specimens of breast cancer. And they found through hierarchical clustering, and if you look nicely here, so the verticals are the patients and the horizontal lines represent the genes. And you can see here, these patterns look completely different. And here you have the luminous, here you have the basal, and you have the HER2 enriched. So they look completely different, like a portrait. And this has also been shown beautifully to correlate with prognosis. So you have the luminal, which are the ER positives, luminal A and B, which do the best. And the worst outcome is seen in the basal light or the triple negatives. Now, everybody can't afford gene profiling. It's expensive, it is time consuming, it is technology driven. So there was a beautiful paper by Rebecca Dent and her colleagues where she said, can you get surrogates of these molecular subtypes through immunohistochemistry? And what she showed here, and you can see on top is ER, PR, HER2, and the basal markers CK5, EGFR, and C14. And you can see on the y-axis in the first cartoon, luminal A, B, HER2 enriched, and basal. And with good immunohistochemistry, you can definitely tell these different molecular subtypes. So high quality pathology is crucial and cost effective, and you can get the same information as to the prognosis by doing IHC. So what does chemosensitivity depend on? So in favor, more ER negative, ductal, high grade, high proliferation, HER2 positive, basal type, they do very well with chemo. ER positives, lobular, low grade, low proliferation, luminal A's, they really don't benefit much. But more than that, we have genomic tests today. So we have Oncotype DX or MammaPrint, which give us more information if there is a mixture of both these factors which can exist in a single patient. So let's go back to the patient who wishes to avoid chemotherapy. And here is a host of, and I'm not going to bore you with the details, of all the genomic tests which are available in and approved, most of them approved by FDA in the clinic today. And most of them are easy to use on good tumor blocks. They are either done by RT-PCR or microarray or nanostring. They are mostly central, and they give you clinical information for ER positive, HER2 negative, early breast cancer, either lymph node negative or between 1 and 3 nodes positive. 3 of these have been prospectively validated, and most of them are approved. So I'm going to focus on just one, which has been around for the longest time. And this is the Oncotype DX, which is a RT-PCR-based score of 21 genes, 16 cancer-related and 5 reference, and it tells you the distant relapse within 10 years. It is developed on patients on tamoxifen treatment and basically divides patients into 3 risk groups. You have the low risk 0 to 10, intermediate risk 11 to 25, and high risk more than 25. And it is recommended for both pre and postmenopausal women with no negative tumors less than 3 centimeters, and in postmenopausal women with node positive tumors between 1 and 3 nodes. So I give this option to my patient, and she is keen on doing the test. Believe me, it is expensive, but if patients really want to avoid chemotherapy, I do this in practice and give them the option. So her result comes back as 10. So she is in the low risk group. So all postmenopausal women with an oncotype score of less than 25 don't really benefit much from chemo. And as you can see here, not only have they told you her recurrence score, they've told you her recurrence at 9 years of 12%, which is very, very average, and absolutely no apparent benefit from chemo. So genomics can give you information over and above clinical pathological factors. Most scores now combine clinical as well. And scores like GGI also tell us, will the patient benefit not from 5 years, but from 10 years as well of treatment? And they are very useful molecular markers for ER positive early breast cancer. So the 60-year-old lady starts her hormonal therapy with aromatase inhibitors, but in her 6th year, she starts complaining of a low backache. She has no relief. She takes orthopedic treatment. She goes back to her oncologist. The oncologist has a high degree of suspicion, clinical suspicion. We do a PET scan and we see multiple bone metastases, especially in the lumbosacral vertebra, small scattered lung nodules, and a right supraclavicular node. The questions here are, would you rebiopsy this patient? What site would you do? What tests would you order? And how will it impact the management of your patient? So when do you rebiopsy? So the recommendation from the guidelines are that you would rebiopsy at the first metastasis, or if some time has passed, or at least once during the metastatic timeline. I usually don't do unnecessary biopsies, but if the clinical features are not in keeping with the nature of the tumor, that is, I have a strongly ER/PR positive tumor, and in 3 years she comes with early breast cancer, and she comes in 3 years with liver metastasis and brain metastasis. That is not the behavior of a ER positive, PR positive tumor. So I will definitely get a biopsy done. So, and if there's been a length of time between the first diagnosis and the metastasis, I would certainly want to know if the tumor is changing. The tissue is also important to get for further molecular testing. And we have seen discordance reported very, very widely from 20 to 45% in many studies. So I've picked up just one meta-analysis, which shows you the receptor change from ER positive to negative, PR to negative, HER2 positive to negative, the most common change being PR, followed by ER, and then negative to positive, which is much rarer. Okay, so it's more common for a positive to become negative. Naturally, as time goes by, the tumor acquires more resistance. Especially in ER positive tumors, they will become hormone resistant. So they will start to reduce their ER positivity, they will lose their PR, and they will acquire a higher grade. In some cases where you pick up a marker which was previously negative, like ER or HER2, this is great because then you can have a target for further treatment. So rebiopsy, I would choose a nodal site which is easily accessible. I would not use the bone. You know better than me how nightmarish it is to do a IHC on this decalcified bone, and it's not always accurate. So the patient is now treated with a hormonal therapy and with something that we use in the clinic called a CDK4/6 inhibitor, which is responsible for overcoming endocrine resistance. So these agents came out about 10 years ago. And when a patient acquires endocrine resistance, there is an upregulation of, say, cyclin D1 or CDK4. And as you know, the CDK4, cyclin D1 are very, very important for the initial part of the cell cycle, that is the G1S progression. Not only is the ER pathway dysregulated, it also has a crosstalk with all the other pathways that you can see in the black arrows, the PIK3 pathways, STAT, MAP, etc. And because there's a crosstalk, there is a hyperstimulation and there is an increase in the cell cycle and the proliferation. So we now have CDK4/6 inhibitors which actually block the CDK4/6 complex and lead to a restoration of regularizing and stabilizing the tumor. So the patient responds very well. She has a great quality of life, and we've changed her hormonal therapy. We've added CDK4/6, and she gets a good 2.5 years before she starts complaining of right hypochondrial pain. And she's now developed new liver metastasis, increase in the bone lesions. Would you rebiopsy again? What kind of further molecular testing would you do? So it's important to remember that there is another biomarker which has great therapeutic relevance called a PIK3CA mutation. So this is hyperstimulation of the PIK3 pathway, and it's seen very commonly in ER-positive patients, and this is evidence from the studies. The question is, why test? Because there is a drug for it today. When to test? You can test on the original blocks or you can test at the time of metastasis. How do you test? An RT-PCR or NGS? And which sample? You try with a liquid biopsy first. Since the patient has metastatic disease, there will be a high load of tumor cells, and you will be able to pick up these mutations, of which the most common is E545, and they occur in exon 9 and 20. And this is the PIK3 pathway that is dysregulated in ER-positive hormone-resistant breast cancer, leading to increased growth, survival, proliferation, metabolism, and angiogenesis. And this is the pivotal study which showed that alpelisib, a drug against PIK3 mutated tumors, works in patients even with prior CDK4/6 therapy and gives you a nice progression-free survival benefit of at least 4 to 5 months. It's not an easy drug to use. I must confess, I've used a lot of it in the clinic, and the main side effects here are rash and hypoglycemia, and it needs very careful monitoring. Because as you know, one of the main ligands for PIK3CA pathway is the insulin-like growth factor. There are other mechanisms of resistance too, and another important biomarker, though it doesn't have much therapeutic potential yet, is the presence of ESR or estrogen receptor 1 mutations. So if you look at the cartoon on your left, you can see the pocket where that's the estrogen receptor, and the estrogen or the tamoxifen that you're using nicely fits in. But what happens with an ESR1 mutation? The entire configuration in this mutation is changed, as you can see here. And nothing really works because none of these estrogen-like stimulated drugs are going to work. So we do have different types of drugs available, and these degrade the estrogen receptor themselves. There is a drug called fulvestrant, which is effective in this population, and now there are oral forms of SERDs, selective estrogen receptor degraders, which are available in the clinic. Some results have been encouraging, some not so encouraging. Let's talk about HER2-positive breast cancer, and I would like to really re-emphasize and emphasize again and again that the most important biomarker for HER2-positive is the HER2 itself. And what is different in breast cancer compared to lung cancer, where you get all these fancy single mutations? You get EGFR, you get ALK, you get ROS, you get MET, you get RET, and you're able to target these single mutations even in resistant disease with newer and newer drugs. And now you have the KRAS G12C mutation, which is targetable as well. You don't have that luxury in breast cancer. Breast cancer has lagged behind, and what you see here are copy number aberrations. So this is a disease of insertions, deletions, duplications, and amplifications. So you see a lot of copy number variations. And it's a fascinating story of HER2. The gene was discovered in the 1980s, and in 87, Slayman found that this gene was linked to breast cancer. And this seminal paper in Science was published where he showed that patients with more than 5 copies of HER2 amplification did very, very poorly. He also found the HER2 protein was expressed, and these patients had a very high propensity, especially for brain metastasis and reduced survival. So he came up with an antibody, got Genentech to kind of invest in it, and developed an antibody to HER2 by 1990. It's a humanized mouse antibody, and it was called trastuzumab. And the very first clinical trial demonstrated a straight-off overall survival benefit over standard of care in metastatic HER2-positive breast cancer. You can see the action of trastuzumab on your left, and you can see that it binds to the antigen binding site of the HER2 receptor, which has an extracellular and intracellular portion. This prevents the dimerization and downstream signaling of the receptor. It also, because it's an antibody, has ADCC activity as well. So there are multiple ways in which trastuzumab acts. Did we improve on trastuzumab? Yes, we gave it a partner called pertuzumab, which binds to a different domain, the dimerization domain. And these two drugs, when given together, have an even better effect than trastuzumab given alone. Again, an unprecedented survival improvement seen by the addition of Trast and Pert versus Trast, and a survival benefit of almost 1.5 years. So just to put it in perspective for you guys, I have patients ongoing with metastatic HER2-positive breast cancer. These people have had liver metastasis and bone metastasis and lung metastasis, and they are going strong on the combination 4, 5, and 6 years on treatment. So it really, really is a great combination. We did even better. We came up with what was called an antibody drug conjugate. So we are clever. We know that chemo is toxic and not very effectively delivered, even when you give it with the antibody for HER2-positive tumors. So through linkages or linkers, stable linkers, we were able to attach the chemo moiety to the antibody. And so to speak, it was an intracellular chemotherapy that was given. And the drug's name is TDM1, and it has shown an improvement in patients who've been previously pretreated with trastuzumab and pertuzumab. And are we only focusing on the extracellular part of the receptor? No, we have, every receptor, surface receptor or receptor tyrosine kinase, as we call it, has an intracellular portion which has the tyrosine kinase domain. And this is targeted by small, smart molecules which can cross the cell membrane. And we have drugs like lapatinib, tucatinib, neratinib against the HER2. So these are also very effectively used, and tucatinib has shown unprecedented activity in patients with untreated and progressive brain metastasis, where it is able to cross the blood-brain barrier, and this is really satisfying a clinically unmet need so far. Okay, let's get back to the antibody drug conjugates. So you see the drug I've talked about over here below, and above it in the deep blue, you can see a drug called TDXT, called trastuzumab deruxtecan. And you can see there are many more chemo entities or attached to it with a high drug antibody ratio and a very stable linker. And the beauty of trastuzumab deruxtecan is that not only does it enter the cell and give out the chemotherapy, the drug can come back. It is membrane permeable. It can come back out. And for those cells which don't express enough of the HER2 receptor, it can directly act on them. And this is known as the bystander effect. So it not only kills the HER2 positive or HER2 expressing cells, but the relatively low HER2 expressing cells which surround these cells. As you know, there is heterogeneity in every type of tumor. So a HER2 positive tumor will have cells with low HER2 expression. And in alert HER2 low tumor, it can also combine and create benefits. And this survival curve, and I keep telling my students that you can actually, when you can see a nice gap between the two survival curves where you can actually almost drive your car through, that's a good survival curve to have, because the hazard ratio is something like zero 0.4, and there is a 60% reduction in relapse in these patients. So we're going to make pathologists' life more difficult, and Dr. Baljeet will elaborate on this, because not only do we want you to report HER2 3+, we also want you to report HER2 2+ and 1+, which today classify as HER2 low, and 1+ and 2+, which are FISH negative, qualify for treatment with this antibody called trastuzumab deruxtecan. There is a trial called Destiny 4, which has shown amazing survival benefit in this group. Let's turn to triple-negative breast cancer. Very difficult tumor to treat in the clinic, and really my heart goes to my feet when I see these young women coming with advanced triple-negative disease. It is a heterogeneous disease. It has many, many molecular markers. So another case for you, a 38-year-old premenopausal lady comes with a painless breast lump of a month's duration. She's very anxious as her older sister of 42 has recently been diagnosed with breast cancer. On examination, a 4-centimeter tumor is seen in the left breast upper outer quadrant, palpable axillary nodes. She has a clinical stage T2N1 disease. Core biopsy shows triple negative, PET scan normal, so a neoadjuvant decision is taken, giving chemotherapy upfront to shrink the tumor, to improve her cosmesis, to look for pathological complete response, and to see in which risk group she belongs, and if she has residual tumor, perhaps to give her more treatment. So pathological complete response is an excellent prognostic marker for the individual patient. Unfortunately, on a trial level, it has not shown a great correlation with event-free survival. But for that one patient who gets a pathological complete response, you do know that their long-term prognosis is exceptional, and they are more likely to get cured. It is defined as the absence of invasive tumor in the primary and the lymph node, and one of the ways of calculating it is the RCB class, which is developed by the MD Anderson group, and we use it very, very frequently in our clinic. You include tumor variables, lymph node variables, you feed it into a formula, and you get your RCB index and class. So, like I said, there is a strong association between pathological complete response and the subtype. You expect 50 to 60% of HER2 positives to get a PAT-CR. You expect 40%, maybe more now with immunotherapy, almost 60% of triple negatives if you use immunotherapy to get a pathological complete response. But in hormone positive, PAT-CR is very rare. It's not even important. It doesn't have a great correlation with the prognosis, and only 3 to 5% of these patients will get a PAT-CR. And why is it important for this particular patient, giving her neoadjuvant and looking for PAT-CR? You can see in this wonderful graph here, in yellow is the non-triple negative. In blue dotted line is the PAT-CR triple negative. See how well they are doing, these two groups. But look at this red dotted line below. You can see that these are the triple negatives with residual disease, and see how badly they do. So it's very important to know if this patient has residual disease or not. So after surgery, unfortunately, this patient had a residual disease of 1 centimeter. Thankfully, the nodes are negative. When nodes are positive after neoadjuvant therapy, especially in this subtype, it is really, really a bad prognosis. But there is data to show that treating this patient for the residual disease with oral capecitabine can improve her chance. And if I happen to check her BRCA and it happened to be positive, then 1 year of a PARP inhibitor would have also been very useful for her. Now, 2 years later, and this is a very common scenario in node positive triple negatives, she relapses. And early relapses, are a hallmark of triple negative disease, first 4 years, and late relapses are a hallmark of ER positive disease. Will molecular testing help? So yes, routinely I send out the biopsy sample for a PD-L1 and an androgen receptor and the blood for germline BRCA. So let's look at these markers a little closely. Triple negative is not only heterogeneous from marker point of view, but also from pathology point of view. And you can range from the real low-grade metaplastic to the high-grade metaplastic to the neuroendocrine and the invasive ductals. So there have been several classifications and classifications on classifications, but we have 4 different molecular subtypes: the basal like, which are highly immunogenic, where immunotherapy works; the immunosuppressed, where there are lots of p53 mutations, they don't do that well, they have lower patch CR. Then you have the mesenchymal level, where again they don't respond that well to chemo. And then you have the luminal type, which mimics an ER positive type. They will go on, they have lots of PIK3 mutations, and they will behave more like the ER positive phenotype. And this is more used for research rather than for practical uses. And early TNBC is a very immunogenic disease. You'll have lots of CD8 positive T cells, dendritic cells. You have a great tumor infiltrating lymphocyte population. But as metastasis occurs, there is all this immunoediting going on. The tumor goes cold, the dendritic cells disappear, the CD8s are replaced by the CD4s and the myelosuppressive, myeloid-derived suppressor cells, and the TIL concentration reduces. But 40% of all triple negatives express a marker called PD-L1, and these patients respond very well to immune checkpoint inhibition. PD-L1 being programmed death ligand. So if you look here, the tumor cell has the PD-L1 and the T cell has PD-1. PD-1 gets secreted when the T cell is activated. So it rushes towards the tumor cell trying to kill it. But the tumor cell is smart. It wants to hide from the T cell. So it secretes PD-L1, which binds to the T cell, not allowing it to recognize the tumor cell as foreign and not allowing it to kill it. But we have been smart as well. So we've got antibodies to PD-1 like pembrolizumab, and antibodies to PD-L1 as well, like atezolizumab. And these then separate the two, don't allow the binding to occur, allow the T cell to recognize the tumor cell for what it is, and finally kill it. So there are several scores which have been used to estimate PD-L1 clinic, but you must remember that every drug, pembro, atezo, durva, each of this has its own approved companion diagnostic, and you should use that diagnostic only for that particular drug. So there is something known as a combined proportion score, tumor proportion score, immune cells, and they all have different formulae and they're all measured differently. So I'm not going to go into the details of this. There is also tumor infiltrating lymphocytes, but rather than metastatic disease, where I said the proportion anyway reduces, there has been very provocative data for early stage. And Dr. Loy is a great exponent of this. And there is actually a TIL website you can go on. You can yourself learn how to estimate TILs, how to count them. And there is early data to show that patients who had a high TIL percentage, they do better. This is triple negative and HER2 positive group. And in this group of TNBCs, for every 10% increase in stromal TILs, there was a 16% reduction in death. So yes, it is a useful prognostic marker. And the last marker that I'd like to spend a little time on is BRCA. BRCA is coming up in a big way, not only for the family, not only for familial risk, genetic risk, also from the therapeutic standpoint. So we have a PARP enzyme, which is responsible for repair, base excision repair. And we have BRCA, which is very good and is the only error-free repair that occurs by homologous recombination repair. So what happens when a cell is damaged? And cells undergo mutation, they keep getting single strand breaks, as you can see in the cartoon here. So when you have a single strand break, the PARP enzyme rushes and it repairs that break. So if I give a drug to inhibit this enzyme called a PARP inhibitor, okay, this single strand break can't get repaired. Besides, that PARP inhibitor kind of localizes that entire repair complex on the DNA, making it a nice bulky complex, which you can see on the left here. And this single strand break then becomes a double strand break. And when you have a double strand break and you're BRCA deficient, you can't repair it through homologous recombinant deficiency, and there is a cell death. On the left-hand side, you can see this is the PARP complex, which is attached. The PARP inhibitor is trapping the PARP enzyme and its complex onto the DNA. The replication fork is coming, but it gets stalled. And this then degenerates into a double strand break. So BRCA mutations, germline, are seen in 15% of triple negatives, and it's a very important prognostic and predictive marker. And here you can see another cartoon on your left side telling you very nicely base excision repair, which is inhibited by the PARP inhibitor, homologous recombination inhibited because of lack of BRCA, no repair occurring, leading to cell death, and this concept is known as synthetic lethality. And this is again more data in the early setting. As I mentioned earlier, if our patient had been germline BRCA positive, you can see we would have given her a drug called olaparib, which is the first developed PARP inhibitor, which shows us a survival benefit today of almost 3 to 4% versus not giving it for a year in the adjuvant setting. And then finally, androgen receptors, they are also important to identify. They have better prognosis. In fact, I have a couple of patients with AR positive triple negative with metastatic disease going for 3 and 4 years on a drug called enzalutamide, which blocks the androgen receptor. What does the future hold for molecular markers? So AI is going to be coming up in a very big way. We are going to go in for molecular imaging. This is a HER2 zirconium labeled radioisotope, which shows you where the disease is present, all the black spots that you can see. Finally, liquid biopsies they've not yet come of age in breast cancer. They are of use in colorectal and in lung cancer, but I do foresee that they will be increasingly used. They are non-invasive. They're representative of different, like the primary is different from the metastasis in its biology. Each metastasis may be different. There may be difference within the primary tumor. So a lot of heterogeneity, which could be captured by liquid biopsies. You could real-time monitor the disease. You could possibly detect it early. You could also monitor your treatments. So they may be used routinely. And finally, technologies have really, I think, overpaced our clinical understanding. And today we have a whole lot of NGS, which is very reasonable, very accessible, and there are a whole lot of labs which have sprouted all over the country. So to summarize my lecture, ER, PR, and HER2 testing are very important in the management of both early and metastatic breast cancer. The relevant molecular markers in ER positive disease are genomic signatures for early disease, PIK3CA mutations, and ESR1 in metastatic disease. A rebiopsy at relapse may be useful, should always be considered. For HER2 positive breast cancer, a 3+ or FISH positive are important, but a new entity HER2 low is defined as 1+ or 2+ FISH negative today has important therapeutic implications with the ADC called trastuzumab deruxtecan. Triple negative breast cancer is heterogeneous, and for metastatic triple negative disease, testing for PD-L1, germline BRCA mutations, and androgen receptors can give us clues to personalized therapy. With this, I end. Thank you for your attention.
Hi, Baljit.
Hi.
Yeah.
Sorry.
I would now like to hand over to Dr. Baljit Singh. He's been introduced earlier, but what has not been said that he is a breast pathologist. So I would like him to make his comments.
Thank you for everything. That was really an outstanding lecture and overview of the clinical implication of all that we do in the laboratory. Something to which pathology residents are typically not exposed to. So this is very well, the combination of prognostic and predictive markers is probably best developed for breast cancer, because we've had at least the estrogen receptor target for almost 3-4 decades at this point, and we've had HER2 for like about 15 years. So, and we have multiple lines of therapy, as Dr. Nag went through, and we have very nice biomarkers in the lab with very nice drugs with very nice response, and thereby the success in treating breast cancer, from a population standpoint. So it's this combination of laboratory work with clinical development of drugs and working on it together. This is pretty much what I do in my academic career. I've taken part in many, many clinical trials and continue to do so for immuno-oncology trials. When do we take questions? Is it now or is it later?
So you can share your PPT if you have, then we can take up questions.
Okay. So I'm just going to, give you, I will not repeat everything that Dr. Nag already did, but I will, since I'm told that most of the folks listening to this conversation are in fact pathology residents, that we have to go to our labs and look under our microscopes to generate all these data for our clinical colleagues to make these very important decisions for patients. So can you see my PowerPoint now?
Yes, sir, it's visible.
Okay, thank you. So this is, Dr. Nag already went through this, that this is the molecular classification in this box, which was initially done with Chuck Peru, with whom I published extensively on TILs, which Dr. Nag also mentioned. I've, continue to work with him on, every day. So from a practical standpoint, as a pathologist, we essentially have done such a good job of doing IHC on breast cancer that we can accurately predict the molecular subtype just by doing immunohistochemistry. It's just that we have to be very careful with these when we do immunohistochemistry for biomarkers as opposed to just diagnostic stains. So the threshold for validating biomarkers in the laboratory has to be much more stringent than, let's say, standardizing diagnostic tests like S100 or cytokeratin or what have you. We have, many, many such tests. So if just to reiterate, so all the first years and everybody's getting used to this new language is familiar. Repetition is important. So if tumor is just ERPA positive, HER2 negative, and typically low Ki67, it gets categorized as luminal A. We do not report these molecular subtypes in our path reports. So they're sort of implied. Luminal B is when it is ERPA positive, may have HER2 positive, and typically has high Ki67. And those are luminal Bs. There are somewhat minor component. This classification, HER2 enriched, is when it is HER2 3+. Typically, they have high Ki67, and for those, we have very, very nice drugs, and patients do very well. And in fact, these patients are downstaged in the latest AJCC classification, if you look at the prognostic staging. And the patients who tend to do the poorly are triple negative breast cancer patients. This is not one disease, it's many, many diseases, but essentially it lacks, it's called triple negative because it lacks ER, PR, and HER2. So that's where the name triple negative comes from. It does express high molecular weight cytokeratins, but we don't have to run those to return this diagnosis. So this is really a very important graph for all the residents here. That you should know this. You might be on your boards and what have you. I'm not going to repeat all this good stuff. Dr. Nag went through this. That HER2 is obviously a very active pathway in a subset of breast cancers, which can be targeted. We have it. When I give the HER2 talk, I always say that HER2 is the poster child for biomarker because we have a very good biomarker test. We have very good drugs with excellent outcome for our patients. So when George Sledge presented the the HER2 trials, people were so excited that he got a standing ovation, which doesn't happen too often for in medical oncology meetings. So We try, as yet, for most of Dr. Nag's talk, we have targeted HER2 to target the HER2 pathway and thereby kill the cancer cells and thereby improve outcome for these unfortunate patients, which from a pathology standpoint is this picture. When you see strong, complete membranous staining, then you're absolutely sure that this is 3+, and thereby the HER2 pathway is active and targetable. The first three categories, when it is completely negative 0 and 1 and 2+, in all the HER2 positive trials, these patients did not respond to the anti-HER2 drugs, and we do not treat this cohort with anti-HER2 therapy. So as pathologists, we define 3+. We've done a very good job of it by standardizing immunohistochemistry, reflexing it to FISH, and if the ratio is more than 2.0 or the copy number is more than 6, then we can very confidently say that these patients are HER2 amplified and thereby candidates for anti-HER2 therapy. What has happened in the last 6 months is, as Dr. Nag mentioned, that we have a new target, which is the HER2 low cohort, to which as pathologists we have not paid as much attention as we will have to moving forward because it has suddenly become targetable. There's only one paper in the metastatic setting showing efficacy of Enhertu in this cohort. So I believe the first sessions, the San Antonio meeting, there are multiple presentations. So we look forward to those to educate us, what the other drugs are going to, how efficacious they may or may not be. So for as pathologists, just to reiterate, we have to focus on this cutoff between 0 and 1+. As yet, you might see your teachers reporting a 0 to 1+ in one line. That we won't have that luxury anymore. We have to be very careful whether the tumor is 1+ or not, because that means whether this patient is going to get treated or not. So this is the new drug, which what is important to understand here is that this drug binds to the HER2 ligand, but does not target the HER2 pathway. It targets, it carries this enzyme which is independent of the HER2 pathway. So it is using the HER2 molecule or the ligand on the tumor cell. I'm sorry, let me go back here. Just as a binding site, it's not targeting this pathway, which the other HER2 drugs did. So thereby, it even when the HER2 it does not have to be overexpressed for this drug to be effective. All right, so this is the trial which showed efficacy of this drug. You can see the patients in the orange did clearly better than the ones in the gray. Again, as pathologists, we don't look at too many Kaplan-Meier curves, but that's something, there's not enough time here for you to learn this. This is how clinical data gets presented. You compare one set of treatment with another set of treatment, and if the curves separate, then that shows efficacy, and they have to separate considerably for it to be statistically significant. So if you go to medical oncology trials, those residents are very familiar with KM curves, and unfortunately in pathology we are not. But so just to give you something that we are familiar with, I'll give you a few examples of cases where there is a little bit of membranous staining, but it is less than 10%. So you would call this IHC 0 for HER2. There's some incomplete membranous staining, but this is more than 10%. And so we would classify this case as 1+. Similarly, there's a little bit of cytoplasmic staining. This would be 0. Here, there is a little bit of membranous staining, but more than 10% cells. So again, this would be 1+. And here, there's only very minimal staining. So this would get categorized as 0. So as yet, we've focused on the 3+ cases. That's what we practice every day. But with emerging data, we will have to focus on the 1+ category more critically, like we did for 3+. And all this is predicated on the biomarker analysis done on one trial. We'll have more mature trials, other data. So it's sort of the story is progressing, just like HER2 story became. It took a good 10 years for it to mature. So this 1+ story will emerge in the next few years with more robust data. So I will stop here and happy to take your questions. And thank you again for inviting me.
Thank you, Dr. Shona Nag ma'am and Dr. Baljit Singh sir, for that very informative talk. Now we have a few questions. First one is what is cold ischemic time? How it affects ER/PR? Ma'am, would you like to take this?
I think Dr. Baljit is a better person to answer these
Yes.
So
pathology questions.
cold ischemia is basically a concept. Cold ischemia, there's hot ischemia, which is not relevant for breast cancer, for the breast in breast tissue, because hot ischemia is for colon, tumors in the colon when the surgeon clamps the blood vessel, but the tissue is still sort of warm while they're doing the surgery, so it's not degrading. In the breast, the anatomy is completely different. So when the excision occurs, the fatty tissue loses its blood supply and starts developing hypoxic damage. Okay, so this is also the way some drugs act, but when the tissue undergoes hypoxic damage, it degrades. So the proteins degrade and it becomes if the tumor is expressing, let's say, estrogen receptor, uh, the uh, the uh, the 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 enzymes which degrade these proteins become active, and that the target that we're trying to look for can degrade. So, based on um, basic science studies and also clinical data, people did experiments. They published data to show that degradation is the least and will not impact clinical decision making if the cold ischemia time is less than 1 hour. So, from the practical standpoint, pathologists need to partner with their surgeons and the nursing team. So, they have to make a note when the tissue came out of the body and write that time on the requisition. And somebody has to physically walk that specimen down immediately, like a frozen section, to the path lab, and it has to be fixed within the first 60 minutes to comply with CAP ASCO standards so that the estrogen and progesterone receptor in HER2 are not compromised, and thereby patient care is not compromised. So this is the standard for assessing. This is what cold ischemia time means as a concept, and also practically what we actually have to do to comply with standard of care every day in the laboratory.
Yes, sir. Thank you, sir. We have another question from Momita Panja. How to calculate percentage of ER/PR if only small percentage of cells at the peripheral part of whole slide shows weak to intermediate positivity, while whole central area doesn't take up stain?
So that looks like what we call an edge artifact. So you have to understand basic principles Dr. Nag mentioned, and of the. So you should not interpret ERPR in challenging cases in isolation. It's just poorly differentiated tumor. Is it a young woman? Does this look like a triple negative cancer? So you have to not just look at the slide. You have to work as a physician, uh, as opposed to just trying to interpret the artifact at the edge of the slide. So something can go wrong. Maybe you look at the technical stuff that maybe the tumor sat around on the weekend and maybe lost its antigenicity. That's our profession. Make sure that doesn't happen. Certain things can certainly can go wrong, but so this is very well established that there can be spurious staining on the edge of any tissue. And from your description, the questioner is really actually describing an edge artifact. So I don't want to interpret that as positive or negative or intermediate, what have you, absent clinical context. So if this is a well-differentiated tumor, you expect it to be ER positive, and it's turned out to be ER negative, I'd be very skeptical of that result. If this is a 43-year-old woman, she's premenopausal, she has poorly differentiated tumor, which is metastasized to her lymph nodes. It rapidly grew in the last 2-3 months. It's a triple negative cancer. So, and that's what it really is, and this is probably an artifact. So you have to interpret these biomarkers in context as a physician and not just interpret what you see through the microscope.
Yes, sir. Thank you. Sir, and we have next question, how to identify, again related to this only, identify false positive ER/PR HER2 new staining and when to suspect false positive staining.
I can just repeat what I said, that play doctor, not pathologist. Understand the medicine first before interpreting the slides, and keep track and follow the CAP ASCO guidelines with cold ischemia, with establishing your assays. Make sure that tests are validated well enough. And whenever in doubt, like it's just general common sense in medicine, whether it's sodium, potassium, or HER2 assessment, when it doesn't make medical sense, repeat the test. When the things don't, when they say, the ducks don't line up, then repeat that. That's very important. Like, you get a potassium of 2.0 and the patient looks normal on the bed. It's not the correct reading. They should be dead. So, so it's the same thing with these tests. You have to, I cannot reiterate to the residents in training that use the skills that you learned in medical school. Play doctor when you're a pathologist. Don't just interpret artifact and results under the microscope.
Yes, sir. Thank you, sir. Last question for you, ma'am. Please mention what are the indications for neoadjuvant chemotherapy apart from T4 stage in case of breast cancers.
Yeah, so thanks for that. And I think that's a separate lecture in itself. So basically, the fact that we used neoadjuvant chemo, it can't even be called neoadjuvant because T4 is inoperable. So all you're trying to do is make the inoperable tumor operable. We've come a very long way since then. We now use, and then from inoperable to operable, the indication then became to make breast conservation possible. So when you had a large tumor in a small breast, your aim was to shrink the tumor so that you could offer breast conservation surgery and followed by radiation, which is equivalent to doing a mastectomy and is perfectly safe. That was the second indication. Today, we've moved beyond that. We want to test the biology of the systemic therapies because, like Dr. Singh alluded to, they are so good, especially in HER2 positive disease. Now, in triple negative disease, we have platinum, we have immunotherapy. So, we want to know the pathological complete response for that particular patient. Should there be any residual disease, we do what is called as risk adaptive therapy, where we give them drugs in the adjuvant setting after completing all the neoadjuvant and the surgery with a view to improving the survival further. So for triple negative, we have capecitabine, we have olaparib in the adjuvant setting. Immunotherapy has to continue if it was given earlier on. For HER2 positive, we don't only give trastuzumab now, we give a drug called TDM1, which I showed you, antibody drug conjugate, if there's residual disease. So we can actually rescue some of these patients with residual disease who would have otherwise done very badly. So when practically do I and my surgeon decide on neoadjuvant? Abroad in the West, even 1 and 2 centimeters tumors, even node negatives get neoadjuvant. We're a little more practical here. So a large tumor, small breast, any tumor more than 3 centimeters in size, especially if HER2 positive or triple negative, and any node positive tumor, which is triple negative or HER2 positive, is when I give neoadjuvant.
Okay. Thank you, ma'am. Another question has popped up. Prognosis of CA with medullary features.
So,
Prognosis.
so this is the divide between anatomy and biology that, there were, when I was a student, everything was anatomy. What is the subtypes of cancer, micropapillary, medullary, mucinous. It's the only which have stood the test of time with molecular classification for which we have level 1 evidence. Level 1, meaning that we have data from prospective clinical trials, is for the grade. Grade holds up pretty well and is incorporated along with genomic, metrics then the size of the tumor is held up very, very nicely, that, and the number of lymph nodes stands up in every trial. 4 or more lymph nodes, patients do poorly. These esoteric subtypes, the medullary cancer, that it is a better prognosis, was always based on observational series, which were very, very small. So in current day practice, we really don't, these morphological classifications are very little of or no use. If you get a medullary cancer, which basically is high TILs, has lots of lymphocytes, so that is a good prognostic factor, and maybe these patients will respond better to chemotherapy based on the current evidence. And then you just have to run their biomarkers, and that's how we would classify that tumor, as opposed to just call it better prognosis based on medullary features or medullary carcinoma. So we've sort of moved away from this subtyping. We, as pathologists, we love these patterns and description of these patterns. This is our sort of comfort zone. But so it's not that you don't have to say it, it's just that it's not actionable intelligence for my colleagues, and I'll want Dr. Nag to comment as well.
No, I absolutely agree. I mean, we've all learned about medullary, and very often than not, it is triple negative. But if it has a great TIL concentrate, they do respond well to both immuno and chemotherapy.
Yes, ma'am. Thank you, ma'am. Ma'am, we have a few more questions. Is there any hope for androgen deprivation therapy in AR positive, triple negative breast cancer, as in prostate cancers?
Yes, so I mentioned that during my presentation. There's no randomized trial because this is not a large population of patients. They're not easy to find. You recognize them in the clinic when they're, they come with metastatic triple negative disease, and they have this typical breast bone node presentation. You give them chemo, they don't really respond. Their general condition is great. They rarely have visceral disease. And then you check for an androgen receptor. So I've had patients like this on androgen receptor deprivation with drugs like enzalutamide, not an easy drug to tolerate again in the clinic. And I've got 2 patients going for 3 years now, doing well with metastatic disease. So yes, there is a role.
So for the pathologist, the apocrine, the cells with apocrine features,
correct,
are more likely to be AR positive. So and I've also published in this so that's what you look out for, and you can always, I would not run it absent a conversation with your medical oncologist, because the anti-androgen drugs, I believe, are only indicated in the metastatic setting, not in the primary setting. So you don't want to run biomarkers without a conversation, because it can be misleading sometimes. Yes. So and the cutoff is 10%. So from the pathologist, you need to know, you may or may not use positive, negative, but in the clinical trial, 10% was used as a cutoff. So that's the kind of thing you need to know on a practical basis.
Yes, sir. Any tips and protocols on selecting the ideal control tissues to be used regularly for these biomarkers?
So it depends on the biomarker. For ER and PR, you should use normal breasts, not a tumor, because you're trying to catch the low expressors. If your assay is standardized with only a high expressor, you're going to miss the low ones. So you should standardize it in your lab using normal breast tissue with differential staining. For HER2, you obviously have to you should use 3 things: negative, 1 and 2 plus, and 3 plus on the same slide. So you have to create a sausage block and use that as a control. And of course, otherwise you can always use cell lines, which you can buy.
Yes.
It depends on the biomarker.
Yes, sir. Thank you, sir. Is there anything specific to diagnose triple negative patients at an early stage? I'm not sure about this question. Is there anything specific to diagnose?
There's nothing specific to diagnose that particular subtype. In fact, triple negative is very notorious that, when a woman has her interval mammogram, or she has, when she has her annual mammogram, triple negatives grow so fast that they're known as interval cancers, and they will crop up between 2 mammograms. So it's impossible to keep imaging. However, if there is a strong family history and one of the immediate relatives is BRCA positive, this patient with triple negative would qualify for genetic testing, which is germline BRCA, or what we call a panel, a hereditary breast ovarian panel, where we do markers like PALB2, etc. And in case she is found to be BRCA positive, then we give them lots of choices of preventive surgeries, but we also do what is called as intensive surveillance to pick up any tumors fast. So every 6 months, it's either an MRI alternating with a digital mammogram. So this is how you can pick up these tumors in a carrier who doesn't already have a germline BRCA positive triple negative cancer yet.
So this concept of early stage is really based on ER positive tumors. You catch them small, you can treat them, they will do better. For triple negative cancers, even small ones, the anatomy is superseded by the biology, that they are bad cancers from the outset. And so the threshold for giving chemotherapy is significantly lower based on the size, entirely on the size. So this whole concept of early stage and triple negative, they're sort of mutually exclusive, unless they're 1 millimeter or something.
Yeah.
Yes, sir. Between the triple negative breast cancer and HER2 enriched breast cancer, independent of breast treatment available, which ones have poorer prognosis?
I would still say if you look at the molecular subtyping, triple negatives still do the worst.
Yes, ma'am. Thank you, ma'am. We have all these were the questions in the chat box. So I would like to thank Dr. Shona Nag and Dr. Baljit Singh, sir, for the explaining the molecular markers in such an excellent way about the breast. And I would also like to thank all the attendees for their active participations in the chat box and as well as for joining up. That's all. So